So welcome to the treatment planning and material selection for tooth-borne cases. It is a webinar being presented by Tremaine Watkins, CDT, and we will begin the webinar shortly. And with that, it is my pleasure to introduce Tremaine Watkins, CDT. He's been working in the dental laboratory industry for more than 30 years. After graduating with a Bachelor of Arts from Trinity College in Issaquah, Washington, as class valedictorian, he has gained extensive experience in all aspects of fixed and removable restorations, with an emphasis on implant-supported and retained restorations. He also has provided clinical support in case planning, troubleshooting, and implant placement. He has trained other technicians in all aspects of dental technology and has written and lectured on several aspects of restorative dentistry. And with that, it is my pleasure to say, take it away, Tremaine.
Thank you, Jessica. Thanks for the warm introduction, and thank you everybody for spending some time with us this evening. I hope everyone will get a few nuggets out of this. So we're going to be talking tonight about case planning and material selection for tooth-supported cases. So a lot of the things that we're going to be talking about tonight are helpful for doing smaller cases like single anterior restorations. We're really going to be focusing on larger cases that have more latitude in case planning. Let's say you're thinking about a 6-unit anterior bridge as opposed to a single anterior. For the single anterior, getting a nice shade match, as you guys know, is very, very difficult. But in terms of the contour, tooth position, stuff like that, it's pretty straightforward because you really need to mirror the contralateral tooth. On the other hand, if you're doing a 6-unit bridge with several ponics, there are a variety of different options that you can choose. And so you really have to have a method for looking at the case and saying, of these 40 options, this one is the best for this particular patient. The larger the case gets, the more options proliferate. So we kind of need a method to look at the case, evaluate it, and decide how to get to that best outcome. So, and again, today we're going to be talking about planning and executing tooth-borne cases. We will talk a little bit about implants, but mostly in terms of single crown type implants. We'll deal with full arch implant supported like all-on-X cases another day. The larger cases, we usually get the best results when we approach them with an interdisciplinary team. So I think most folks on the call are general dentists, and for those that are, you're the quarterback of the team. But it's nice to have a team of specialists who can take care of specific aspects of the case for you. And then it's also good to have a capable laboratory to actually make the restoration so you get a nice result there. This kind of seems obvious, but it can cause a lot of problems. You know, we need to start out with a thorough understanding of the patient's desired outcome. When I think about some of the most problematic cases that I've faced over the years, quite a few of them originated from poor communication. Either the clinician didn't understand the patient's expectations or didn't communicate what possible results there were, or we in the laboratory didn't communicate effectively with the dentist. This is really the golden age of restorative dentistry, in my opinion. When I started in this field many moons ago, there were cases that we really couldn't treat with a fixed restoration. We'd have patients who were missing all their posterior teeth, and the best we could do for them was a precision partial with a 6-unit anterior bridge or 6 single anteriors. These cases were difficult to do, time consuming, and so you worked really hard, you got a super okay solution. It's like, oh, awesome. In other cases, we'd offer a fixed solution, but we were using so many ponics that we knew that the case was not going to be very durable. And then that doesn't even take into account the cases that you deal with where a lot of aspects of the execution on both the clinical and the laboratory side were good, but the aesthetic results weren't that great just because of the materials we had. So today there aren't a lot of people who can't have the results that they want. But for us to deliver those results, we need to know all the options that are available, and we need to talk about the costs and timing for treatment. Another thing I think that's really important is that we need to understand what we would like for the case, but when we go into our conference with the patient, we need to put that aside and make sure that we start out by understanding what the patient wants. sometimes we can get so wrapped up in what we want to deliver that we kind of force them into something, and then they're frustrated because we never really heard what they want. So one thing I think that's a good discipline, especially at the beginning of this process, is to really use active listening, to listen to the patient and then repeat back what you're hearing. So that way they know that you've understood them, that you've heard what they're saying. Last but not least, we need to think about the nature of words and communication. The point of what I'm saying is for me to take ideas from my head and get them to you. So if you don't understand the words that I'm using, I'm sure you all do in this case, but then I'm not being a very effective communicator. One of the things that can be difficult in dentistry is that we have a lot of precise terms for various things, but they can kind of seem like mumbo jumbo to our patients. So what we really need to focus on is using words, not talking down to them, but using words that they understand so that we are communicating clearly, both understanding what they want and talking about what we can deliver. Once we understand the patient's expectations, we can really help all of us out by getting the patient to see in their own mouths what our treatment looks like. We'll need to make sure that we talk with them about if there's any materials or biologic limitations that might prevent our desired result. And there can be, there's a range on this. It can be, one time I had a case that was very difficult, and it was basically that the patient wasn't happy because the crown didn't perfectly match in her poorly lit with yellow bulb bathroom and when she was outside in daylight. And so we had to explain to her, and too bad we didn't do this ahead of time, metamerism and different things like that. But that was a real problem on that particular case. On the other hand, sometimes your patient needs a major alteration in their bite, and you need to try to explain to them what it's going to feel like when you change their whole occlusal scheme. The time invested in patient communication at the front end is probably some of the best time you can spend on these cases, because you're going to get much better satisfaction at the end. This is where we underpromise so that we can overdeliver at the end. Not surprisingly, comprehensive dental treatment is often expensive. Now, there are probably more dental financing options than there's ever been for patients to get all their treatment at the same time. But there are going to be times where patients want to maybe stage to take advantage of dental benefits. And we kind of need to think about not just the beginning and the end, but we need to think about the middle stages. Are we going to be able to get a good result at each step? And if we're going to see some intrinsic cosmetic challenges on these cases, we want to make sure that we communicate clearly about that. Let's talk about like an upper full arch case done in 3 segments. Let's say we do, 2 to 5, 6 through 11, and 12 through 15. So you look at the case and you tell the patient, okay, I can get your 6 front teeth all looking the same in the ideal position, but there may be a little bit of space between them and your back teeth. And I need to build up your bite a little bit. So there's going to be color line between the build-up material that I bond to your tooth and the tooth itself. And if the person's fine with that, if they're choosing to do stage treatment, then that's great. If they don't like that, then we need to figure out how can we do the treatment and get them the result that they need. If we need to do all the treatment at the same time, then I feel like that's a fair conversation to have. Another thing we need to think about is healing phases. A lot of the things that we do will require us to do some treatment and then wait for it to heal. And so we need to be thinking about how we're going to provisionalize during those stages and how we're going to keep the patient looking as good and functioning as good as they possibly can. Sometimes there's more than one option. Let's say we have to do a single anterior implant. It could be that an immediate provisional would be the best solution for the patient in terms of giving a nice ideal tissue contour, but maybe a cover screw and a flipper would be more affordable. So we share those both with the patient, and the more we get the patient involved in this process, the more buy-in they have. So it's not my bad idea as the treatment professional, but it's their idea And so therefore, for most of us, if we think it's our idea, it makes it intrinsically better. So we're seeing the beginning of true 3D facial scanning right now. And I think it won't be long before an STL of the person's face aligned to the models on which we're working takes place in traditional photos. Right now, however, most offices still communicate patient information via photos. So we need to see a relaxed lip image to see the maxillary incisal edge position, which is basically where all tooth position originates. A normal smile to see the buccal corridor, incisal edge, and midline inclination, and the position of the occlusal plane. And then we need a grin, Duchenne, high smile, whatever you want to call it, to evaluate gingival display. We should also have smiling and relaxed profile views to look at our lip support. Relaxed views are very helpful for clinical diagnosis, but not as relevant for your laboratory in terms of prosthetics. Now, for a lot of these cases, the patient's just going to pick the shade and that'll be that. But if we are taking a shade, if we are trying to match a natural shade, the photos are critical. First, we need to take a photo when the teeth are hydrated, which is before we do any treatment. This is important and often different from current shade taking practices. Second, we must be sure that we have light of adequate spectrum and intensity. Color is not like mass. As you know, mass is the same no matter where you go. But color is the way that an object interacts with the light. So if you change the light, you change the color, even if the object is the same. You change the means of perception. The color seems different even though the object is the same. So the first thing we got to think about is the light that we're using. We can only see the true color of something when all the wavelengths of visible light are present. In light bulbs, this breadth of spectrum is the color rendering index, or CRI. So the CRI is a percentage of the spectrum of visible light emitted by a bulb. And we want to make sure we use bulbs with a 95 CRI or higher for taking shades. Second thing we need to understand about shades is that our eyes are delicate shade-taking instruments. About 1 in 12 men are colorblind, while only 1 in 200 women are affected. There are simple online tests you can take to evaluate color blindness. Even if we evaluate that and we see if we can perceive color correctly, our eyes can easily be overwhelmed by too much light or fail to discriminate color with too little. However, with all their limitations, the human eye is still the most accurate gauge of color. Spectrophotometers and colorimeters can be helpful tools, but their inability often to adequately deal with translucency ensures that usually a perfect match requires a human eye. Many people's teeth are going to have slight variations in color from one to the other. When selecting a shade for a single tooth or small region of the mouth, it's important to show the patient which teeth we're selecting to match and what the effect of matching a given tooth will have on the overall appearance of the patient's smile. Sometimes the adjacent or contralateral tooth is not the best one to match. You want to try to pick the shade that will enhance the appearance of all the patient's teeth, but do your best to make the patient aware of the challenges that will result from a given shade. I've worked with several cases where I'm doing a single central, and the contralateral tooth is the darkest slightly of all the other teeth. And so if I notice the laterals and cuspids are a little bit lighter, I'll point out to the patient, I can match these other 4 teeth, and then that will make those 5 look really good. There will be a slight discrepancy in color. And again, it's all about the communication. Some patients say, great, I want you to make my teeth look better. I want to do 1 crown. Some patients say, well, I don't want that. I want all my teeth to be the same. And then that's a good opportunity to talk about comprehensive dentistry and what we can do to meet those expectations. Good photos are critical to capturing good color information. In your laboratory, this is probably, some of you probably know this, but if you send in a patient for a custom shade, most of the time, the hard work in the laboratory is getting really, really good photos. So if you can get really good photos, you can get very similar results to a custom shade without sending your patient to the laboratory. So first, you want to get good shade tabs. As you see in this photo, you want the shade tab to be no more than half a shade different from the body color of the tooth. You can choose several shade tabs if a tooth has, say, intense incisal translucency or gingival pigmentation. But you want to start out by getting the main color for the tooth, if you will. It's really important that the shade tab be in the same plane facially as the tooth. If it's too far to the buccal, it'll usually look brighter than it is. And if it's even a little bit lingual, the shadow will make it look darker. This has always been an issue, but I've noticed with cell phone pictures that I think are the norm these days, it's even more pronounced, that effect. So really having someone, it's kind of a two-person job to take these photos, because one person needs to hold the shade tab perfectly and the other person needs to take a photo. Take quite a few photos, and then while you still have the patient there, look at them. You'll be amazed as you're looking at your camera and then looking at the patient, you're like, how did this even happen? This picture looks nothing like the person. So only send the laboratory the pictures that really match nicely to the teeth. As you guys know, we're using our radiographs primarily to evaluate how stable a foundation the existing teeth and bone will be for our restorations. Obviously, in the image above, the lower incisors on the right side of the image have so little bone around them that they're not stable enough for any kind of restoration. They're going to have to be extracted, and the underlying disease processes that cause this bone loss will need to be addressed. We need to remember, and probably more, we need to communicate to our patients that tissue follows bone. So when these teeth are extracted, the tissue will remodel to the biologic width, which is going to leave a huge defect. So if the patient wants to get really, really nice aesthetics, we need to do hard and soft tissue grafting, and probably a couple implants would get a great result. The person says, well, that seems expensive. I don't want to do that. I want to do a 4-unit bridge. Then you need to explain to them kind of the differences in gingival lengths that are going to occur. And keep in mind that pink porcelain is kind of treated as a panacea, and it rarely is. What we often see with pink porcelain, especially in small segments like this, is that there's a seam all the way around the outside of it. And so it becomes pretty apparent what's pink porcelain and what's gingiva. If we adapt the porcelain nicely enough to make that go away, a lot of times we wind up with a very intricate ridge lap, which can be difficult for the patient to keep clean. Again, it's about communication. For some patients, a 4-unit bridge with some pink porcelain, they're going to be okay with that. They're going to be like, my lip never goes down that far. I understand exactly what you're saying, and I'm very comfortable with that. But what we don't want to say is, oh yeah, the pink porcelain will make that problem go away. And then when it doesn't, the patient's like, well, you said it'd be perfect, and now it's not. So again, you can see the importance of patient communication. Of course, we also use our radiographs to check for internal infections that could require endodontic treatment, in addition to bone loss we're talking about. So another thing that is important for patient communication is what we have to do to salvage the teeth and how effective our salvage effort is likely to be. With the advent of effective root-formed implants, we have a good alternative to placing restorations on teeth that will probably fail. If teeth are questionable, patients should be made aware so that they can decide whether they want to make an investment in a restoration attached to a tooth that they might lose, or extract the tooth and place an implant. This evaluation comes early in the process because we need to know which teeth will remain to support our prosthetics. We need to factor implant healing, osseointegration time into our treatment plan. When addressing missing teeth in our full arch cases, longevity of the restoration, return on investment can be part of our presentation. Compared to a ponic or removable restoration, I think most clinicians would agree that dental implants are the closest to natural teeth in fit, form, and function. However, they are also likely to give longer service. At 10 years, the average single tooth implant case has a 95% success rate, while a 3-unit bridge only has an average life expectancy of 8.3 to 10.3 years. In other words, a patient's implant will probably be in service in 10 years, and even a 3-unit bridge perhaps will not. This discrepancy gets even greater, as you know, due to the biomechanical loads if more ponics are added or cantilevers. Furthermore, if the proposed abutment teeth for a bridge are currently unrestored, we want to think about the fact that treating the missing tooth with an implant allows us to leave those teeth alone, whereas we have to remove 65 to 75% of the coronal aspect of the tooth in order to make a bridge. Bite becomes more critical the larger the case we're treating. A lot of times when we're treating a single unit, the best we can do is make the restoration harmonize with the patient's existing centric and functional occlusal scheme. However, if we're restoring all the teeth in a quadrant, or especially if we're treating a full arch or full mouth, we're really only providing the best treatment if we optimize the patient's bite. A number of years ago, I remember that there was a huge focus on making CR and CO coincident. And I think it can be very valuable to do this. I think we can feel comfortable restoring a case in a habitual bite if the patient's TMJ is asymptomatic. But I would say most of these patients, we're going to really need to address VDO. Most patients who present for full arch or full mouth treatment of lost vertical dimension due to attrition, tooth loss, tooth mobility, and we're providing them with the best service if we restore that lost VDO during on treatment. I alluded to this earlier, but I want to talk about it for a minute. When we're going to be talking a little bit about how you decide what size teeth you should use and where you should put them. And all that begins with the incisal edges of the maxillary anterior teeth. Looks youthful to show 1 to 2 millimeters of incisal edge with the upper lip at rests. When you're trying to communicate this with your dental laboratory, study models are really important. So you can take a preoperative model and say, and look at it, you're like, okay, the incisal edge is 1 millimeter above the lip. So I'm going to need 2.5 millimeters of incisal edge length added. Once we know where that position is and we know where the free gingival margin needs to be, then we really know all our proportions for the case. Again, as we're restoring a lot of these cases, we'll find that we have space between the arches because we're trying to recreate the missing space. So once we get those incisal edges figured out, that shows us where our occlusal plane needs to be to build up the upper and lower appropriately. It's really important when you're getting started on a case like this that you use an iOS or PBS, polyether, something like that to capture the models. We're going to be articulating our study models and then trying to preserve that articulation with any other models we use, either digitally or physically. So we want those impressions to be very accurate and to be large, capturing the palate, capturing the vestibular borders, so that we can align our models to each other. It's not only helpful for preserving the bite, and we'll talk about that a little bit more, but it's also good when the patient says, oh, my teeth were super awesome before you started treating them, and you can show them the models and say, okay, well, was this super awesome? Or, oh, I didn't know they were that bad. People forget stuff, as you guys know. So we'll begin with those cross-mounted duplicate models of the pre-treatment situation. First, we're going to make any planned extractions on the model, shaping those extraction sites for an ideal gingival margin. As you guys know, we get the best aesthetic results with ovate ponics, which can be delivered pretty easily with an immediate restoration, even an immediate provisional, but they're going to require a little bit of surgical intervention to be placed in a healed rid. So we want to keep that in mind as we're planning the surgical side of our cases. We'll definitely want to take some time to examine the gingival symmetry and relationship of the gingival margin to the upper lip at high smile. Aesthetically, the gingival margin should not be more than 2 millimeters below the upper lip at high smile. And I would say this is a bit of a moving target. You guys know what you see in your practices, but I think people are getting closer to wanting 1 millimeter than 2 millimeters on this. Small changes, we can sometimes, like a millimeter or less of a discrepancy, can be made by prepping the crown a little bit deeper into the sulcus. But significant changes in gingival height will require crown lengthening. When looking at asymmetric gingival lengths for existing teeth, keep in mind that it's much more predictable to lengthen the shorter gingival margin through crown lengthening than to shorten the longer one through hard and soft tissue graft. If you'd like a guide for crown lengthening, your laboratory can first reset the free gingival margins on the study model, then make a splint showing the desired free gingival margin. As shown above, the stent is used during surgery to precisely guide bone reconstruction. So now let's talk a little bit about basic rules of tooth design and position. As we previously mentioned, aesthetic tooth location begins with the incisal edge position of the maxillary centrals, both incisogingivally and buccolingually. Keep in mind that the buccal lingual position of the maxillary anterior teeth determines lip support and facial profile, but don't compromise tooth morphology to gain additional lip support. If the patient wants the buccals of the maxillary anteriors over contour to support the lip, make sure that he or she approves the tooth design before manufacture. This kind of alteration puts an unsightly bulge somewhere in the buccal contour that can not only make the teeth look odd in profile, but it can warp the perceived ratio of length to width, making the teeth look kind of wide and ugly. So we want to make sure that that we advise against it, but if the patient wants to do it, we need to make sure we let them see how those teeth are going to look before we go to final restoration. One advantage of the all-on-X cases, as you guys know, is that we can pretty much put the teeth wherever we want to. And, you know, there's always a compromise. We'll sometimes wind up with a little bit of a ledge, but that is one of the constraints with the tooth-borne cases, that with tooth-borne cases, our contour has to emerge from the margin. So we want to make sure that when we plan or set a case up for one of these, that we're planning so that so that we can get a good facial shape. We also want to keep in mind that the maxillary incisal edge position affects speech, and a lot of times a good way to check and see how we're doing is to see with fricatives if the incisal edges of the upper teeth hit the wet dry line. We want to make sure that the apical portions of our pontics mirror the form and length of the contralateral teeth. And we want to warn the patient if there is significant tissue loss that's going to make an asymmetry. And one other trick that I think is pretty important is when you're preparing this margin and this margin, the mesial margins of the maxillary centrals, try to prepare them as symmetric as possible, and keep in mind that from an aesthetic perspective, you're better off putting the contact directly between the two centrals than aligning it with the facial midline or the lower midline. I've seen a lot of cases that look pretty terrible because we gave up some midline symmetry in order to move the midline. As long as the midline is straight, most of the time, if we move it 0.5 millimeter, it's not going to be noticeable. That coronal asymmetry is really, really difficult to hide with restorations. Now, as you go more posterior, it's a little bit easier, but right there at the midline, very difficult to do. So barring any patient-specific variants, we want the incisal angle of the maxillary anterior teeth parallel to the interpupillary, and we want the midline parallel to the facial midline or perpendicular to the interpupillary line. If you have a patient who has noticeable facial irregularities that give them kind of a midline a facial midline that's going to be different than their dental midline, it's good to not only talk to them about that, but figure out a way to get a mock-up in their mouth so that they can see the solution that you're thinking that will be best for them. It's best to fight with that kind of stuff in plastic than it is to make final restorations and redo them. That's not super fun, as you guys know. There's a few other rules of anterior tooth position that can be helpful. First is centrals flat to the front. They can follow the arch form a little bit, but in general, the case is going to look best if the centrals are flat both in profile view and in incisal edge view. We want cross arch symmetry and pleasing proportions. Golden proportion is a good basic rule, but I think most people feel like this, this drawing shows 80% length to width. So in other words, if this central were 10 millimeters long, it'd be 8 millimeters wide. Seems like there's a lot of discussion about this, but I'd say 0.72 to 0.78 are a good number, both for length to width ratio and for central to lateral ratio. So in other words, the surface area of the lateral is that same percentage relative to the surface area of the central. You want to think about your gingival and incisal length of your teeth. Oftentimes you want the gingival and incisal lengths of the cuspids and centrals to match on the maxilla, of course, and then you want your laterals to be about 0.5 millimeter to no more than 1 millimeter shorter at both the apical and the incisor. You want to look at your line. Well, this is something you'll see more in your laboratory, but if you see a crown that looks kind of funny or some kind of restoration that looks kind of funny, sometimes it can be that the line angles aren't symmetric. The overall shape of the tooth is the same, but say one line angle is a little bit depressed or something like that. Another trick that we laboratories do that's good to think about is we want to close any dark triangles from the lingual. So what we want to do is contour the buccal ideally, and then if we have to over contour a little bit to close a dark triangle, we want to do that from the lingual. Otherwise, the facial surfaces of our teeth will look kind of bulky and have not awesome emergence profiles. A good general rule of thumb when you're looking at your overall anterior contour is that it should be convex in every dimension on the labial surface. In other words, it should be convex, gingival to incisal and mesial to distal. If it has a bit of a, it can have some little concavities here and there for contour, but if the overall shape is concave, it makes the tooth look weird. There's a few things that can kind of, you look at the tooth and you're like, well, it should look right, but it doesn't. And sometimes if you turn that restoration angle, you'll see, oh, looks like a little ski ramp on the facial. That's what's wrong with it. So that can be really important. We want to develop even centric occlusion on our functional cusp in the posterior, and we want to avoid lateral interferences unless we need to do balanced occlusion for some reason. In general, it's nice. There's a lot of theories on this, but in general, you want to do cuspid rise and anterior guidance. But make sure that you're evaluating your patient's chewing habits and different things like that to make sure that you get that you're selecting good occlusal scheme. So we know the rules, we know where the patient's at. We need to start designing the patient's final restoration. This can be done with analog or digital methods. For analog method, we'll prepare the teeth on the articulated model and either hand wax or scan design and mill teeth in the ideal tooth position. Digitally, either do a photo orientation Photoshop method of relating a proposed design to the patient's face, or 3D facial scanning to actually design the case oriented to the patient's face, like you see on the right here. Once this template is approved, this is what we're going to follow for the provisional and final restorations. We've talked about overlaying for the patient, and this is the stage where we want to get that overlay done. If there's any way, especially if we're, say, adding a little bit of bulk on the facial surfaces or something like that, it can be really nice to scan the existing teeth, design a thin PMMA shell, and actually bond that to the tooth. And then the patient can see what we're talking about. Now, a couple things about that. One is, like you see the prep shining through here on number 8 on the left-hand side. That'll probably happen in real life with some of these mock-ups. So it's important to talk to the patient about this is a mock-up for contour, not for shade. That's really important. In our bite opening cases, it's great if we can bond onto the occlusal surface of the posterior teeth. So that way the person can start test driving our occlusal scheme and we can work it in a little bit. One nice thing about these PMMA overlays is that we can bond into place and then just prep right through them. The one challenge is when we're doing crown lengthening. If we're going to just put the mock-up in, let the patient see it in the office, then we can go ahead and just overlap the gums. But if the person, as you guys know, if the person's, we're going to bond it to place, we can't do that because, of course, we got to make the case hygienic. So sometimes showing that crown lengthening can be difficult or nearly impossible with a bonded restoration. So you'll need to kind of work through that. So we've looked at the case, we've mocked it up, we've gotten the patient to see, okay, I like this solution. Now we've got to make up a treatment plan to figure out how we're going to get there. Again, as the general dentist, you definitely want to lead this process, and then you want to involve your specialist in the lab based on the needs of the individual case. Obviously, you need a healthy mouth as a foundation for this kind of comprehensive treatment. Of course, we have to control any periodontal disease, and we need to make a plan to prevent recurrence. And one of the things we need to talk about is, do we think that the patient is going to do the necessary home care? If we make a very, very complex restoration that's difficult to clean, and we don't see that we don't think the patient is going to follow through on it, then we're probably not doing them a service. Maybe the right thing for that patient is to do a implant supported removable, like a conus or a locator, where the person can take the case out, clean it every night more easily, and be less likely to get back in the situation they were when we found them due to home care issues. Again, we want to talk about endodontic treatment and the potential longevity of any treatment we do. We also want to think about orthodontics. It's kind of interesting that people do implants all the time with an eye towards, oh, it's going to take me 4 or 5 months to get my final crown, but I'm okay with that. But all of a sudden, we start talking about ortho and they're like, oh, that takes too long. I don't want to do that. Well, one thing I think that we can do to help our patients is explain to them the benefit of having the tooth in the right position as opposed to kind of warping it with prosthetic contouring. Ortho, as you all know, has become quicker and more predictable. And I think sometimes we give up a little bit too easy. We can be pretty adamant about an implant treatment, but sometimes we're not as adamant about orthodontics. So I think, and again, I think it depends on the case, but if we look at a case and say the most important thing is to get these teeth in the right position, then we should be as adamant about that as we are about other time-consuming interventions. We want to be, again, looking at our ovate ponics and make sure that we're planning to avoid ridge laps and other things that cause trouble. Especially if we're doing crown lengthening, what a great time to sheep up an ovate ponic as well, so that way the person can only have one surgery. We'll want to make sure we have a nice ovate provisional ready to go so that we can do a rough prep on the teeth and deliver that to help preserve that ovate ponic shape during healing. I love that definition of implant therapy that is a prosthetic discipline with a surgical component. That's the fancy way of saying people buy teeth, not implants. So let's say we place the world's greatest implant. It's surrounded by bone, not like my one down here, but it just, everything is perfect about it. But we put an ugly tooth on it. The patient isn't going to say, let me see that x-ray. I think that's a great implant. They're going to say, this is a terrible implant. What they really mean is, I don't like the tooth position. So we want to make sure that we keep ourselves out of that situation. Historically, the word has been, don't put two implants next to each other in the aesthetic zone. I've seen a couple studies recently that are saying that there are some implants that have good enough crestal bone retention that you're not getting that flat conic shape in between. But I would say still in general, the safer procedure is to try to figure out a way to not put two implants next to each other. If a person's missing 6 and 7, instead of putting two implants in there, a lot of times we can put a large implant under number 6, cantilever a nice ovate ponic into 7, and we'll definitely have better capillary form long term. We want to also make sure that our platform size and position create an ideal emergence profile for our teeth. If our implants are too shallow or too narrow in diameter, they can look like a popsicle, which isn't a good thing. And it's both unaesthetic and unhygienic. It's nice, we want to make sure we use large implants for large teeth and small implants for small teeth to get a nice looking and healthy emergence profile. Also, our running room, as you guys know, is important. We want to make sure that we place the implants deep enough so that we can get adequate emergence angles, but not so deep that we encourage tissue loss to where we wind up with our implant crowns looking a lot longer than our adjacent teeth. A lot of times we forget to manage the apparent length of an implant crown, and it winds up being too short or too long relative to the adjacent teeth, and the patients aren't happy with that. A lot of times 3 millimeters below the adjacent free gingival crest is ideal. So if we're doing these comprehensive cases, and so we're placing maybe 1 or 2 implants to replace the missing teeth, we need the implants in the perfect position. The worst is implants that are angled buccal. A lot of times you can get in situations where those just can't be restored aesthetically. The gingival aspect of the restoration winds up looking so bulky, or it has a hole through the facial or something terrible like that, that it's just a real disappointment all the way around. Sometimes we place the implants a little too lingual, which is safer, but we wind up having to create a little bit of a buccal ridge lap so that we're matching our emergence angles, and then we're creating a hygiene problem that we didn't need to have. With most of these cases, we're going to be moving the tooth position a little bit. So one of the challenges with placing implants is that we tend to place them based on the surrounding teeth. But if our goal is to get the teeth to a new position and have them in the right position, you're really going to have a better result with a guided case, I think, in these situations. Because then what you can do is use your mock-up, use your wax-up, use your facial scan plan, whatever it is that you use, and say, okay, I'm going to put the implant smack in the middle of the planned tooth, regardless of how it relates to the existing teeth. And that way we know that when we move to our final configuration, we're going to have the nice aesthetic, functional, hygienic outcome that we'll get for our patients. If you're making a master model for a tooth-supported guide, you should use an intraoral scanner or PVS polyether. Don't use alginate, because at the end of the day with guided surgery, the fit of the guide determines the accuracy of the surgery. Another advantage of doing guided surgery is you know ahead of time where the implant's going to be. So we can make gingival formers or provisionals ahead of time to shape the tissue for optimal results. As you guys know, stock healing abutments are some version of round, except for maybe mandibular incisors. None of the roots of natural teeth are round. So if we get a perfect implant position, our next issue is to get a good tissue shape for an ideal cosmetic result. There's usually a way to generate a printed model that shows the proposed analog position based on a surgical guide. And sometimes you can even get a digital model, so to speak. That way you're doing the whole thing in digital space. So in your model, then of course, you know, the tissue is going to be or can be reflected. So we want to shape an ideal emergence profile, and then we want to create whatever we're making to that profile. We can make a custom immediate temporary crown, which can be really nice. We just need to make sure that our patient's going to be compliant. You tell them it's only for show, not for go. We want to leave it at least a ½ millimeter out of occlusion in every possible movement. Tell them they can't chew on it or they'll lose the implant. But a lot of people like getting a tooth. I mean, the goal of getting an implant is to get a tooth. So the sooner we get them to a tooth, I think the happier they're going to be. We can make a hand-formed custom healing abutment in a flipper or a Nesbit. It works fine. It's difficult to do, and it's difficult to impress. And we'll talk about that in just a minute. And then there's also the Atlantis custom healing abutment. I mentioned this because this is the only one I know of where you can input your planned position, get an ideal emergence profile from your laboratory, and then when you get the final abutment, the emergence profile will be exactly the same. When we do custom healing abutments, custom provisionals, whatever, one of the things that was a problem in the past is that then we got to figure out a way to capture it. So then we'd have to take an impression pose, put a bunch of resin on it to capture, and that was really a pain. This is where iOS has really shined. With an iOS, you just pull the provisional, scan the tissue for its lumps, then put your scan buddy in there. It really has made, I think, custom tissue management much more viable than it was in the past. So we got our template figured out, and we got to kind of figure out what our next steps are. For opening the bite, we're definitely going to want to do a PMMA occlusal overlay bonded to our posterior teeth to let the patient feel the bite. A little trick with that is it's nicer to have those made in single segments. So like a 4-unit segment, then you bond it, then segment between it. Because bonding those individual pieces is kind of a pain. It's a lot easier to get in there with a needle burr and just open up the contact a little bit for flossing. As you can see with this person, since we were adding incisal length and buccal position, we were able to put some bonded restorations on there so that she could see, okay, this is where my teeth are going to be. And the nice thing is if you bond those on, you can just prep right through the PMMA when you're ready to prepare the case. So now we kind of know what we need to do, and we need to do our sequencing like we talked about. We're going to want to start with any orthodontia we're doing because all our treatments are going to reference tooth position, and we're going to want to have stable, accurate tooth position. We also want to get our implants put in as quickly as possible, get our necessary grafting done, our custom healing components, shape our ovate sizes, our ovate tonics, and then do any crown lengthening as well, as much as possible. I'm sure most of your patients will be happy if you tell them I could do 1 surgery or 2 surgeries. Most are going to say the smaller number is the one I like. Bite changes, we want to get into those early as well, because it's really nice to have a stable bite before you go to the final restoration. One of the things we want to work with these cases is to, by the time we get to the final, we already know where the teeth need to be, the patient's seen it, we know where the bite is. It makes our final much easier. So there's no one size fits all strategy for these cases, as you guys know. This is one of the things I like about interdisciplinary study clubs. I've been in quite a few. I'm not in one right now, but boy, do I enjoy those. It really helps me understand what each specialty brings to the table. And it's also cool to see how we can all work together. Everybody kind of contributes their expertise, and the plans and the treatment that we do becomes so much better than if I'm the limitation of my own treatment planning. So finally, all our pre-treatment work is done and we're ready to go. So before we get going on the preparations and that sort of thing, we want to make sure we evaluate stuff, because we know where we wanted to be and we need to find out, did we get there? We really want to look at gingival symmetry and the like, and talk with our specialists if there's problems. Is this all we get, or can we get a little bit more? Once we've had that conversation, then we need to talk to the patient and say, do you want to do what we got to do to get where we wanted to be, or are you comfortable with the changes it's going to require? Tooth position from orthodontia, also very important in this conversation. And you'll kind of need to make a judgment with your mock-up. If you think that the variations are small enough to where we can still achieve what we've shown the patient with the mock-up, that's fine. But if we've had some pretty substantial variations, we may need to redo our diagnostic information, because at the end of the day, what we're going to try to do is make our finals look just like our mock-up. So we kind of need to make a decision about records. We have our mock-up that's articulated in the correct position and has our proposed tooth design. If we think we can meet that, we shouldn't mess with it. We can take some photos of where the patient's at with our mock-ups, but we want to leave that as kind of our master registration. If significant adjustments had to be made, especially the occlusion lens, say, we'll want to take a new face bone and see our bite and mount that new set of models, which will then become our master for the final treatment. It's a good idea to label those with a Sharpie, mount them on the same articulator so that things can be easily cross-mounted for review later on. And again, kind of designate this one as our master. This is where we're headed. So at this point, everything else we do, we're going to be trying to preserve our tooth position and occlusal scheme as we're moving forward. We're not trying to reinvent the wheel. We already have a good wheel. We just want to put the right car on it, I guess, using that analogy. The provisional is going to be the patient's best opportunity to see the planned results in his or her mouth. And it's critical that we get a good result. As you guys know, anybody who's done a case like this, prepping and pressing a full arch like this is time consuming, and you feel a little beat up by the time you're done, from what I hear. I'm a dental technician, I've never done it, but I have talked to a lot of people about it. So we want to make the provisionalization as predictable as possible so that we get a good result for the patient. We're not killing ourselves at the end. So the first thing that most everybody's heard of is eggshell provisionals, which look like this, basically. So in the laboratory, we take the mock-up, we reduce it 0.8 of a millimeter all the way around, and we mill it out of PMMA. And this sounds like a really cool idea. Problem is that the margins, we're guessing at the margins. Nobody knows where the margins are going to be until you go in there and prep them. So that can be an issue. And the other thing is that it's very difficult, you'll find, I think, to prep to one of these. You'll try to seed it and it wiggles. It's really frustrating. You can make reduction guides and different things like that to make this more predictable. But just keep in mind, this makes the outside of the restorations look good. It makes the occlusal scheme good. But boy, fitting this can be a bit of a challenge. So just know you're getting into that. The second option is to make a putty matrix. And so what we can do is take our mock-up and do a 2-part putty matrix that sits on some stable point of reference that won't be prepped, like maybe the palatal tissue, maybe a little bit of the buccal and lingual tissue on the mandible. You want something that'll give you a good stop, and then some vent holes in the lingual. So then when you prep the case, you fill this up with resin and form the provisionals in the mouth. The nice thing about this is you can kind of prep it however you want, because as long as your preps are within the morphology of the planned provisional, then it adapts quite readily. The challenge with this is that there's a fair amount of chairside finishing that you have to do, and it's harder to get a really nice surface finish on there. Sometimes you can put a little optiglaze on there and that'll give you a nice result. Myself, I think that they're both difficult, but that's easier. The third method is if you have a chairside mill. What you could do ahead of time is scan your mock-up and make sure you got a big enough model to align to your prepared case. Then you prepare the case, scan that, align them together, and do a biocopy to mill out a bunch of PMMAs. That'd take a while to do, but it would give you the ability to have a really good fit and really good morphology. So I guess what I'm saying is that I don't think there's a one-size-fits-all solution. So make sure you talk to your laboratory and you guys make a plan that works best in both of your hands. A lot of times with these cases, the patient's going to pick the shade and say, I want to be an OM2. And so when we do our mock-ups, we want to make sure we show the patient what this looks like so that they realize how it looks for them, not how it looks in a magazine or how it looks on somebody else or whatever. As mentioned before, if for some reason we're matching some existing teeth, we want to make sure we take all our shade photos and our shade information before we start treatment. Because once the teeth start dehydrating, and some dehydrate pretty quickly, the shades we capture are going to be too light, and then they won't look really good when we're done. We're not trying to take a bite on the day of the preparation. What we're trying to do is retain the bite that we've already established in pre-treatment. There's a few different ways to work with this, but one thing that I don't think a lot of people have tried is pick a few teeth. Like, let's say pick the cuspids and the first molars. Prep everything else. Take an impression of that. Then prep those 4 teeth and take your master impression. In the lab, we can use the preoperative models to mount up, make a putty matrix, mount up on those 4 teeth, and then do a transfer bite for the rest. We can also digitally align things, which can give you a nice result as well. So again, one of the things we want to do is use that nice articulation that we made and align the preps to it, as opposed to taking another bite when everybody's tired. You're tired, the patient's tired, everybody's tired. Before you're done with the preparation, make sure you look at those ponic sites for symmetry and make sure you're going to be able to get a good result. If not, now's the time to make some adjustments. If you're making some big, I don't know, people call rapid orthodontics, if you're prepping the teeth a lot to be able to move the tooth position, sometimes it's nice to have a clear shell from the mock-ups, and you can poke little holes in it and then measure your reduction with a perio probe. Make sure that you've reduced enough all the way around. If you align the anterior preps more, especially when you're doing all ceramic restorations, you'll get a better result. Also, us laboratories, we can block out dark underlying dentition, but we have to use opaque restorative material, which generally don't look as nice. It's better if you go ahead and over reduce and block out a little bit with composite before you take your prep to get a nice predictable shade. The last thing I'd say about preparations is that this area right here on the preparation is critical for shade. A lot of times, if we're doing a layered restoration, we need to put dentin and incisal ceramic there. If we're doing a monolithic restoration, we're trying to curve that contour in just a little bit. And if the prep sticks out in that area, it can really make the aesthetics not as nice. You'll sometimes see those crowns that look like they have a blue racing stripe on them on the incisal, and this can be part of the problem. So sometimes it's good to go back when you're all done and just lay that in just a scratch to give your lab a little more material, a little more space to make a nice result. IOSs are awesome for these kind of cases. So if you take a scan, you're like, oh, that prep didn't pick up too good, just rescan it. Any of you that have done these kind of impressions, these are difficult to do. And if you put a couple implants in there and you're trying to get all those margins and your impression copings picked up and all that stuff, it's difficult. So if you can get a hold of an IOS to do these cases, I think you'll find that it makes it much more predictable. Couple little things about provisionalization. If you're doing veneers, you're going to want to spot bond the buccal surfaces before forming the temps from a putty matrix. I would not recommend doing eggshells for veneers because they are so hard to reverse prep to. I think forming them from putty is going to make it a lot easier. If you did an immediate, let's say you did an immediate implant temporary that was probably matched to the patient's existing shade, and now you're going a little bit lighter. You'll probably want to have a spare cylinder on hand, temp cylinder, in case you have to remake the whole provisional. Sometimes you can just grind it down a little bit and make sure you hide the transition line, then reform the exterior surface with your putty matrix. Once you get your provisionals in, take some nice pictures. If it's just minor adjustments that we need to make from the provisional, don't make another model. Because again, we want to go back to our template. If we need to make some significant adjustments, then it may be worthwhile to go ahead and take a study model, and we need to figure out a way to mount it. Just because if the bite was way off, then something might have been wrong with our pre-op materials. And last but not least, you want to use your good judgment on the day of surgery on the occlusion, especially with a lot of these cases where we're, let's say, correcting an occlusal deficiency. So we went to a lot of time to get the right bite, get everything in the right position, and the poor person is tired, you're tired, everybody's tired. Sometimes what's good is to just make some rough adjustments and then tell the patient, come back in a couple days. At that point, they've had the opportunity to wear it a little bit. They're starting to adapt. I hear it takes about a week for people to adapt to these big changes in their occlusion. But at that point, you can make a more accurate adjustment and make sure you're not giving away all the good work that you did to get the occlusion correct. If there's issues with the occlusion, your lab is probably best served by holding off a little bit on starting the finals until we have a solid occlusion for our restorations. So when we're doing the restoration, if you're doing these cases segmentally, you want to be sure that all the restorations in the anterior quadrant are delivered at the same time. No matter how we're doing this in the lab, and for those of you that do your own lab work, you've probably seen how it's like, okay, well, I milled it out of an A1. How come these two look different? There's a little bit of an artistic touch in here. And so the easiest way to get everything to match is to make them the same time. You also want to evaluate your patient's aesthetic expectations, because you may want to include the first premolars in the anterior segment. When we're doing the crown contours in the lab, we want to work on a solid model because we need to see those tissue emergences and stuff like that. One thing to keep in mind during design, this doesn't really affect you guys, but the tissue is irregular. And so if we design directly to the tissue, we get irregular, ugly looking emergence profiles. So we need to kind of push on that tissue a little bit to get that nice, smooth shape for the patient. One of the cool things about this is that we've already worked out the occlusion, we've worked out the tooth position. At this point, what we're really working on is texture, perfecting the alignment, things like that. I like to think of every job that we can do, it's going to take a certain amount of time. And there's two ways we can apportion that time. I can spend more time at the beginning and less time at the end, or I can spend less time at the beginning and more time at the end. Obviously, what we've been talking about is a process that's going to take longer to treatment plan and provisionalize. But what I think we'll find is that it makes the restorative step almost automatic. Because at that point, it's just like you and your laboratory just say, okay, we got a plan, let's just implement it. And I mean, that's not perfectly easy, but it's easy to evaluate. You can look at the two models and say, is it the same? Is it not? So by spending the extra time at the front end on this planning, it really gives you the ability to make your restorative process much more. So let's talk a little bit about materials selection. I'm not going to say everything there is to say about this, but we'll talk about a few things. So we need to first think about mechanical properties. We want to look at one nice thing about having the patient provisionalized or mocked up for a while is we can look at the kind of wear that's been on it. And if the wear seems excessive, then we know, okay, regardless of what the person tells us, they're bruxing, there's some parafunction going on, and we're going to need to plan for that, probably in terms of a night guard, but also in terms of the material put in there to make sure that it can withstand the load. With dental materials, there's usually a trade-off between strength and aesthetics. And we need to find the right blend for each restoration within a case, and each case's requirement is going to be different. One of the things that we can do early in our patient treatment conversations and stuff is to talk about this continuum, if you will, and say, so if I have the option of making your teeth a little bit prettier where they might not last quite as long, or if I can make them really sturdy, what would you like? Most patients kind of have one or the other at the forefront of their mind. Obviously, we also need to use our clinical judgment with this, but again, understanding what our patients want gives us a much better chance of succeeding. This next thing is really important. It is really, really good to use the same material for all the units in the aesthetic zone. What I've found is that even if I'm able to get all the anterior 6 or 8 units looking the same on the bench with different materials, when I get them in the mouth, the varieties in optical properties cause them to look different. You'll see some look darker, some look lighter, this sort of thing. And then if you get a high smile, it makes it that much worse. So we want to, the same things we've talked about. We want to minimize the problems. We want to talk about any problems that we have with the patient long before we're delivering the restorations. And you kind of need to decide, do I want to use layered or micro-layered restorations or monolithic? With a template-based procedure like this, it's nicer to do monolithic units because then you can exactly digitally copy the template. If you're doing layering, though, your laboratory can use incisal edge matrices to make sure that the layered ceramic comes out in the same place as the plane. Gold crowns. In some ways, I'm talking about a section, you're like, what's with the gold crowns? But I mean, let's face it, a gold crown is durable, it's biocompatible, it's very easy on imposing dentition. Really, the only thing that's wrong with a gold crown is it's expensive and ugly. So there are going to be some patients where this is the best restoration for their second molars. If you get a patient that says, I don't want this to break, and you see where you prep the teeth, they were all flat, might be a good case to put some gold crowns in there. Just some of you probably know this already, but there's 2 different ways of classifying dental alloys. One is by reactivity and one is by mechanical properties. And you can kind of mix and match a little bit. So most of the time we're going to be doing type 3 and type 4. Every once in a while for an inlay, a nice type 2, type 3 combination can be good. And then for nobility, it has to do with how reactive it is in the mouth. So the noble alloys in dentistry, which are different than chemistry, of course, are gold, palladium, and platinum, and they have to be 40% gold. Noble metals, they got to be at least 25% of those 3 alloys, but they can be whatever mix of gold you want. And of course, non-precious don't need to have any precious alloys in them, although sometimes they do. In general, you're going to be less likely to have allergic reactions with your high noble alloys. And for your full cast, your high nobles will tend to be a little bit yellower. Every once in a while, you're going to get patients who are like, I only want pure metals. And as you guys know, in reality, we need alloying because there aren't any pure metals that have all the physical properties that we need. And especially when you get into ceramic alloys, if you're ever doing a PFM, getting the non-linear thermal expansion curve of an alloy to match the very linear expansion of ceramics, not the easiest thing in the world. If you have specific alloy requirements, this is a good thing to really reach out to your lab for, because your lab deals with materials stuff all day, every day, and they'll be a really good resource for you. So they have little things called identiloys. If you've never seen it before, it shows all the information about the alloy, like what's in it and strengths and different things like that. So you can easily get those. Most of your labs can either rent you or loan you an ingot of the alloy if you want to do skin testing for allergies. So there's some good things you can do with that. So I would say zirconia, we all do a lot of zirconia. It's an awesome high strength material. Full contour zirconia, it's getting prettier and prettier. So I think we can come further and further forward with it. One of the things we have to think about though is when we change materials, there's usually a visible transition. Again, even if the colors match perfectly on the bench, the difference in optical properties can be noticeable. So for our highly aesthetic cases on the maxilla, especially if we have class 1 occlusion, a really nice solution can be doing some lithium silicate, lithium disilicate in the anterior, and then doing a layered ceramic behind that with a zirconium occlusion to protect. Zirconia can also layered, can be a nice solution when we need bridges in the aesthetic zone. Zirconia gives us nice, as you know, shade control of underlying discoloration, either from dark preps or titanium abutments. But zirconia isn't magic. You need a certain amount of depth to get that shade control. So if the reduction's not quite enough, sometimes we can still see a little bleed through. When we're making the case in the laboratory, if we see a little bit of grayness from an underlying metal abutment, sometimes a gold hue or an anodized can really be nice. We want to make sure in the lab we don't mess ourselves up. We want to do provide plenty of 1.5 millimeters of facial thickness so we can get a nice shade. You also have the option of doing zirconia abutments in the anterior. If they have a titanium interface like this one here, probably be fine. If it does have a zirconia interface, you do want to talk to the patient about the possibility of failure, because you're usually only doing those in cases where you have to have perfect aesthetics. So again, cases where the patient wants aesthetics, if they have to choose between aesthetics and durability, they're going to come down on the aesthetics side. In general, it's better to do an angled screw solution than a cement retained solution, because that way we can avoid any potential cement-induced periimplantitis. One other little trick that maybe a lot of people haven't heard of is a screw-mentable crown. A screw-mentable crown is a normal cement retained looking abutment and then a crown with a screw hole in it. And so what you do is you seat the abutment by hand, take your fill, make sure it's good, seat the crown, cement them together, and then you can remove the whole thing as a unit to clean out the sulcus. So you get the easier contacts of a cement retain and the hygiene advantages of a screw retain. If you want to do that, make sure that you explain to your laboratory what you want by screw-mentable, because for whatever reason, I've seen a variety of different definitions of that. Lithium silicate or disilicate restorations are good for premolars and anteriors. I'd say they're the restoration of choice today for bonded restorations, veneers and inlays and onlays, because they have a nice combination of strength, aesthetics, and predictable bonding procedure. They look great as monolithics and come in a variety of different translucencies. that they can be micro-layered for even enhanced aesthetics. Keep in mind that one of the challenges with increased translucency is it often decreases the value. So if you have a patient who wants very light, very translucent teeth, and you're trying to choose a puck or a block, if you're doing your own milling, let's say, you'll probably want to go a little bit lighter because the higher translucency will drop the value just slightly. Studies have shown that these restorations tend to be noticeably longer lived if they're bonded rather than cemented, but they are strong enough to be cemented if necessary. If you're doing a veneer next to bridge case, I would say a lithium silicate or disilicate veneer next to a layered zirconia bridge gets a nice aesthetic result. You can make up to a 3-unit bridge into the premolar area with Emax if the biomechanical situation allows. But sometimes you could overload those bridges. So you can see that following a predictable workflow that starts with thorough treatment planning can make full arch or full mouth cases a predictable part of clinical and laboratory treatment. When the provisionals have already shown the patient the final results for the case, much of the stress in making and delivering the final restorations is eliminated. Your delivery appointment is going to be much less stressful because everyone knows what to expect. As an aside, as the technician, I would say try and get some nice clinical photos of the delivered restorations for your lab. As you have, your laboratory team has worked really hard on those restorations, and they love to see what a difference it makes in somebody's life.